This morning we're going to start talking about liver transplants. So liver transplants have come a long way in recent years due to advancements in surgical technique or organ procurement, advancements in immunosuppressive therapies. And patients with liver transplants now really go on to lead, brand new lives. They go from having end-stage liver disease, having to deal with the complications of that, to having, long, healthy lives. There are some criteria, that have to be met in order to be placed on these donor websites, donor lists. So we're going to go over that in just a moment. But some of the criteria, that they look for to determining end-stage liver disease is elevated serum bilirubin. They look at their INR climb time, other creatinine levels, as well as a mental function test. So common indications for a liver transplant, it's going to be hepatitis C, patients with alcoholic liver disease, cryptogenic cirrhosis, primary biliary cirrhosis, biliary sclerosis, cholangitis, patients with Budd-Chiari syndrome, which is important to differentiate Budd-Chiari from portal vein thrombosis, because we're going to see in a moment that portal vein thrombosis is actually a contraindication to liver transplant. So as long as this patient, has had clot in the hepatic veins in the drainage system, liver transplant is still a viable option. We can deal with that. But if the patient's had thrombosis within that portal vein, then now becomes a contraindication because we can't get blood flow to that transplanted liver. Patients with hemochromatosis, which is an iron overload, Wilson's disease, autoimmune hepatitis, acute liver failure, and as well as early stage hepatocellular carcinoma. Okay, so these are some more indications. So potentially if a patient had acetaminophen poisoning overdose, that could be another indication. They sent their liver into shock from Tylenol overdose, cirrhosis, cholangitis, hepatitis. Basically cirrhosis, hepatitis, like liver poisoning if they accidentally overdose on Tylenol, cirrhosis again, cholangitis, and then hemochromatosis and Wilson's disease. So there are some contraindications, some absolute contraindications for patients, they're looking to get liver transplants if the patient has extrahepatic malignancy. So if they have metastatic cancer that's spread, hepatocellular carcinoma, if the lesions are large, greater than 5 centimeters, or there are more than 3 tumors greater than 3 centimeters in diameter. Diffuse infiltration from malignancy, so if they've had metastases to the liver that are spread through the liver. Complete thrombosis of the portal and superior mesenteric veins. If the patient has an active or uncontrolled systemic infection, we're unable to do a liver transplant. Patients who refuse to give up alcohol or substance abuse. So that's some of the questions that they'll ask you when you are applying, to get on these organ donor lists, like, are you willing to give up all these things, give up alcohol, give up substance abuse? And if it's found out, that you do, start drinking while you're on these lists, you'll be automatically taken off. Severe cardiopulmonary disease, which creates a significant comorbidity for surgery. So it makes that surgery for organ transplant, very complicated. And non-compliance. So if you're just a non-compliant patient, you're not following your doctor's orders, you're not following medications. If you have a history of non-compliance, they're not going to accept you on these organ donor lists. They're also going to look at other factors like your age, other types of cancers like cholangiocarcinoma, so cancer within the bile ducts, portal vein thrombosis. So if it's not completely thrombosed, if it's just partially thrombosed, it could be a relative contraindication. Previous malignancies. They'll look at as well your mental status, like if you have psychiatric disorders, they'll make you at-risk patients for non-compliance. For social support as well. Patients with HIV, potentially. I mean, now HIV, they've come a long way with suppression medication, so that may not necessarily be the same issue as it used to be. So there are two main types of organ transplants when we're talking about the liver. You have an orthotopic liver transplant. So this is a whole liver from a deceased donor that is transplanted into its normal anatomic position in the recipient. There's a wide variation of post-surgical anatomy due to variations in vascular and biliary connections. So the liver is in its general, position, anatomical position. The variations lie within the vascular connections and the biliary connections. Most vessels in common bile duct are connected in an end-to-end fashion, anastomosis in an end-to-end fashion. The second type of transplant is going to be a partial or split liver transplant. So due to organ shortage, partial liver transplants from a living or a deceased donor are now done. A liver from a deceased donor can be divided into two recipients. So one patient can get a right lobe, the other patient can get a portion of the left lobe. Children often undergo partial or split liver transplants. So single lobe transplants have become more common in recent years. Donors usually heal easier as liver is one of the few organs that can actually regenerate quickly. Adult donors provide the right portion of his or her liver to an adult recipient and the left portion to a child. Donated right liver will have a right hepatic vein, right portal vein, and right hepatic artery, and the left hepatic bile duct. This is reserved. This is reversed if the left lobe is donated. So it's the left lobe, the left hepatic vein, left portal vein, left branch of the hepatic artery, and the left branch of the hepatic duct, hepatic bile duct. The middle hepatic vein may travel with the donated liver or remain with the donor, depending on the surgical plane and whether the medical segment of the left lobe is harvested. Pediatric patients will often have a choledochal jejunal connection or anastomosis and no gallbladder. So what that's saying is that common bile duct is going to be connected directly to the jejunum. So the bile secretes directly into your beginning of your small intestine. And common with, regardless if it's pediatric or an adult transplant, they almost always remove the patient's gallbladder. So the recipient's gallbladder gets resected. This is just a diagram showing some of the types of liver transplants. So you can see if you receive a segment, either the left lobe or the right lobe, and the vasculature that's associated with it. So during an OLT transplant, Once it is decided that the liver is suitable for donation, organ procurement team will harvest the whole liver from the donor, including the extrahepatic vessels and common bile duct. The liver is transported to the recipient on ice in a preservative solution. The implantation team removes the recipient's native liver and gallbladder. This is called the anhepatic phase of the transplant. The orthotopic liver transplant with the surgical connection sites. So one you see is the portal veins. Two is the bile duct, 3 IVC, and 4 hepatic artery. So a living donor transplant involving the right lobe, seen on the other side, with the surgical connection sites, anastomosis sites. So you have 1, the portal vein. 2 is the bile duct. So that looks like that choledochojejunal anastomosis connecting directly to the beginning of that small intestine. You have connection then with the IVC, the hepatic vein up here joining. You have the right hepatic vein connecting directly to the IVC, and 4 hepatic artery. Yeah, so that's a right branch of the hepatic artery connecting. So anastomoses are connections. So the standard liver transplant includes 3 vascular connections, 3 anastomoses, and 1 biliary anastomosis. Oh, good. Hello. So the liver has, like I said, 3 connections. So we have 3 vascular. That's going to be our portal vein, IVC, and hepatic artery. So again, remember that our portal vein provides the majority of our liver flow as well. So 80% coming from the portal vein, 20% coming from the hepatic artery. And then we have a drainage connection, which is going to be our IVC anastomosis. And then we also need a biliary drainage connection. So we have a biliary anastomosis. So our portal vein connection, our portal vein anastomosis. So the portal vein is typically anastomosed or connected in an end-to-end fashion between the donor and the recipient's main portal vein. So if we look at our picture here, we can see this echogenic border showing the connection site. In cases of portal vein thrombosis, adequate flow may be established with interposition graft. So that could potentially be an external iliac artery or saphenous vein from the unaffected portion of the recipient's superior mesenteric vein or renal vein. So what they're saying is, if a patient does have portal vein thrombosis, if it's not a complete portal vein thrombosis with the superior mesenteric vein being thrombosed as well, they could potentially do a little makeshift graft. So they'll harvest either the external iliac artery or use the greater saphenous vein and make a connection from that superior mesenteric vein, the unaffected portion of the superior mesenteric vein, and drain that blood flow into the liver, because we got to get blood flow to this, surgically transplanted liver to ensure that its survival and viability. So without that portal vein flow, the liver is not going to survive. So they can potentially make a little graft, get a bypass around the area that's occluded or thrombosed. In this picture, you can see a portal vein and the hepatic artery and the arrows. They're demonstrating grayscale and color image. So intercostal grayscale and color Doppler images obtained from the anterior axillary line show porta hepatis along the long axis. Grayscale, the portal vein is easily identified. Often hepatic artery is identified only with color Doppler imaging. If the donor's portal vein is scarred or thrombosed, a venous junk graft will have to be created to bypass that thrombus. So that is that use of those either external iliac artery or saphenous vein, creating that bypass graft to get around the thrombus. So we have our two inflow connections with the portal vein and the hepatic artery. We also need now a drainage connection. So this is going to be our IVC anastomosis or connection. So a conventional bicaval technique. So in this, the recipient's IVC is resected, and both and IVC of both recipient and donor are sutured with a suprahepatic and infrahepatic end-to-end IVC anastomosis. We also have a piggyback technique. This is a end-to-side connection between the donor IVC and the common stump of the recipient's hepatic vein. The suprahepatic donor IVC is connected end to side with the recipient's hepatic venous confluence. The donor infrahepatic IVC is tied off distally. This is the preferred method because there's a decreased operating room time, creation of only one anastomosis site, and you're able to maintain recipient's cable flow during surgery, so no need for venous bypass. There's decreased retroperitoneal dissection and decreased risk of hemorrhage. So here with the orthotopic liver transplant, when they're taking that whole liver, they would connect the IVC. So they would remove the portion of the liver that has the IVC drainage. They remove the IVC below, the IVC above, and you'd have two connection sites. So with the piggyback technique, this leaves the recipient's IVC in place. And attaching just above the level of the liver, the suprahepatic donor IVC to the recipient's hepatic confluence. The portion of the donor's IVC connecting to the confluence where it would normally connect. So this is the more common method now, particularly with the split donations being more prevalent now. This is just showing a longitudinal view obtained through the liver, showing staples and arrows of an end-to-end IVC anastomosis. So this image is obtained through the liver, and the inferior vena cava shows the staples of the end-to-end anastomosis and the middle hepatic vein and the normal hepatic parenchyma. So you can see an MR imaging of that same patient, showing the right hepatic vein connecting there to the IVC. So this is that piggyback IVC anastomosis. So this is called the fish mouth technique. So with the piggyback technique preferred now, they leave the recipient's IVC in place, and attaching the suprahepatic donor IVC to the recipient's hepatic confluence. So they have the portion of the liver with the portion of the donor's IVC, and they have the recipient's IVC remaining in place, and they connect it to that confluence, that circle where you see all the hepatic veins coming together. So you have one connection draining into that confluence from the recipient's hepatic veins. So there's also something called the fish mouth technique, where the hepatic artery connection is created with smaller vessels walls splitting and sewn together over larger, usually the donor vessels. This is a hepatic artery connection now. So usually a fish mouth. It's an end-to-end connection whereby the smaller vessel walls are split and sewn over a larger donor vessel. The arterial connection is usually made between the donor's common hepatic artery, or the celiac artery, and the recipient's common hepatic artery, and where it branches into the right and left hepatic artery, or the common hepatic artery at the level of the gastroduodenal artery. This technique helps to prevent development of post-surgical stenosis at the hepatic artery connections. So if the donor's or recipient's vessels are diseased, the surgeon may use the donor's iliac vessels to patch or bypass a part of these stenotic vessels. So when evaluating vessels, one should remember that there are several anatomic variations of the hepatic arterial system, and the course that the artery takes may not necessarily be the exact one. The complete evaluation of the hepatic artery may require a great deal of scanning and numerous acoustic windows. Then after our vascular connections, we have biliary connections. So this includes a choledocholeostomy. This is creation of an opening in the common bile duct for drainage. The donor's bile duct is preferentially connected to the recipient's common hepatic duct in an end-to-end fashion. The patient's cholecystectomy is performed, which is the removal of the gallbladder. Another potential option is a choledochal jejunoostomy. So this is performed if the recipient's hepatic duct is deformed, short, or absent, or diseased. So that is a connection from the biliary system draining directly into the jejunum. That procedure does come with some risks. There's increased risk of bacterial overgrowth, as well as anastomotic breakdown or bleeding. So now that you have a direct connection, to the intestinal tract, you do run that risk of bacteria from the intestinal tract working its way, back up into the biliary system and potentially into the liver. Just angiogram just showing the connection, biliary connection. Sonographic examination technique. So Doppler ultrasound is considered the first line imaging modality of choice for evaluating the transplanted liver during the perioperative and postoperative period to detect vascular complications. We can use it also for assessing for perihepatic fluid collections. We can assess for intrahepatic collections. of masses, as well as biliary complications. Preparation, patients should be fasting overnight to minimize bile gas, and also to evaluate the size of the bile duct. These patients are going to be supine or left lateral decubitus. Going to use our curved array or 2 to 5 megahertz curved array. Consult surgeon or obtain surgical report to find out what type of transplant, vascular connections, and biliary connections were done. So that'll go a long way, rather than you trying to figure out, is it a left lobe? Is it a right lobe that's been transplanted? Is it the whole liver? Where did they make the connections? If you can get your hands on that surgical report or try and speak to the surgeon before, doing a post-operative scan, you're going to save yourself a lot of trouble. Use transabdominal, intercostal, and subcostal approaches. So use multiple windows. Grayscale evaluation for liver parenchyma, biliary tree, and perihepatic spaces. Then we want to search for fluid around the liver, potential lesions or fluid or collections within the liver. We're assessing, the biliary tree, looking for biliary dilatation, maybe potentially pneumobilia. We can wind up with gas or air within the biliary system. And the most important aspect of this is going to be our color and pulse wave Doppler. So this is where we're going to be able to determine, has this transplant been successful? Does it appear that it's going to take? And it's also important in serial follow-up exams to ensure the health and the longevity of this transplant. So we can potentially, assess for changes in Doppler flow and kind of get ahead of it and make necessary corrections and alterations to these connections to try and preserve that liver transplant. So color and pulse Doppler interrogation of the main and intrahepatic artery. We also do interrogation of the portal vein, hepatic veins, IVC, and their connections. We're going to document patency and flow direction of the intrahepatic and extrahepatic vessels. So ultrasound is the main initial management modality for evaluation of liver transplant and complications due to high sensitivity and detection of vascular and biliary complications. So we perform daily Doppler ultrasound for at least 3 days. And then following that, we do at regular intervals of 1 month, 6 months, and 12 months after transplant. Then we're going to look at our splenic vein, superior mesenteric vein, portal vein, hepatic veins, IVC, and hepatic artery. So first exam, it's going to be done 24 to 48 hours after transplant. And every 3 to 5 days for the first 2 weeks, and then 4 weeks after. Understanding the potential post-transplant complications and the strengths and weaknesses of each imaging modality will aid in early diagnosis and timely management. So our grayscale imaging, this is important for assessing the liver parenchyma. We want to ensure that it appears heterogeneous, it's appropriate in size, with normal appearing biliary tree with no dilatation. Duct wall may be thickened if biliary stents are in place. And a small amount of perihepatic fluid in early postoperative period is normal. So it is okay for these patients to have a little bit of fluid post-op. So then we have also our color and Doppler analysis. So we're going to have our velocity measurements of our intrahepatic main, right, and left hepatic arteries with resistive indices. We're going to also assess the main right and left portal veins with their connection sites. We're also going to assess the IVC, as well as the right, middle, and left hepatic veins if present. So if vascular communications are detected, vascular complications are detected intrahepatically, the recipient's native vessels may also be assessed to determine the level of dysfunction. So if you see dysfunction within the liver itself, go outside the liver. Continue to look at the splenic vein, assess the spleen, see if the spleen appears enlarged. Check the superior mesenteric vein, see, make sure there's proper flow direction within the SMV. An issue with the hepatic artery, check the celiac. Look for other complications further out. So the normal postoperative findings with the hepatic artery. So normal hepatic artery waveform is going to be a low resistant waveform. So it's it's organ flow, bringing blood flow to the liver. So it's going to have a higher diastolic component. We're going to have a fast acceleration time. So we're going to look for acceleration times that are less than 0.08 seconds. So we want a nice fast upstroke. Resistive indices are going to be between 0.5 and 0.8. Normal graft may have a resistive indice of greater than 0.8 in the early postoperative period, but this resistive indice should slowly go down over time. Hepatic artery anastomosis velocities should be less than 200 centimeters per second. So if we have over 200 centimeters per second, this could indicate potential stenosis or narrowing of that artery. Another thing to also take note is early increased diastolic flow in the hepatic artery with an RI that is less than 0.6 has been reported as a predictor of impending vascular complication. We'll see in a moment. In the immediate postoperative period, it's going to have a high resistant waveform. So this is showing the hepatic artery immediately postoperative. So this is a high resistant waveform pattern. And as we move further out from that day of surgery, we start getting lower and lower resistance with more and more diastolic flow. A couple of days out from surgery, we have our normal appearing hepatic artery flow. Again, so we're looking for nice fast upstroke. We don't want any sort of sign of a targus parvus waveform, so nice fast acceleration time. And gradually increasing resistive indices. So normal postoperative findings for portal vein. So a normal portal vein waveform, we should see a nice anechoic lumen with regular contours and smooth walls. There should be mild reduction in caliper or echogenic shelf-like ring from the surgical clip, maybe seen at the connection site. We should have a nice monophasic continuous flow towards the liver. And we can have a slight respiratory phasicity. Again, turbulent flow may be visualized in the early postoperative period. And the normal portal vein size should be between 1 and 1.5 centimeters. So mismatch between donor and recipient portal vein may be seen and is particularly common in pediatric transplants and should not be mistaken for stenosis of the portal vein. Normal portal vein size should be less than 1 to 1.5 centimeters. Normal postoperative findings for our hepatic veins and IVC. So this is now our drainage vessels. Normal hepatic vein IVC, so we should have our triphasic waveform reflecting right heart pressure. So we should get our W's. A monophasic waveform may indicate obstruction or may be due to compression of the vessels. Could be due to compression, could be compression of the IVC or those extrahepatic anastomosis or connections, and this could potentially be results of ascites, so a large amount of fluid within the abdominal cavity, or a large transplanted liver in a small space, or during deep inspiration. So potentially, if you have a large liver in a small space, could compress the vessel and reduce that respiratory variation that we see, and resulting in a more monophasic waveform. So follow-up. You should perform follow-up closely. So our triphasic waveform in the hepatic veins will eliminate rejection diagnosis. So that's an important criteria as well. So normal Doppler features in a liver transplant. We have a main hepatic artery in the porta hepatis. We got a resistive indice of 0.67. That falls within our range. Our main portal vein showed a continuous hepatopedal flow towards the liver. We were able to visualize and see the piggyback technique of the connection with the IVC. So we have an anastomosis of that, again, donor's portion of IVC connecting to that confluence of the hepatic veins, which drains into the IVC. So in D, we see the donor and recipient's IVC in transverse view. You can see the donor IVC, recipient's IVC. More superior transverse view at the level of the donor hepatic confluence in the same patient. And then when we did our Doppler analysis for the right hepatic vein, we get a nice triphasic waveform. We want those nice pulsatile flow within our hepatic veins. It's a good sign that rejection can be excluded. And waveforms in the IVC and all the hepatic veins should appear fairly similar. So a high resistant arterial waveform in the main hepatic artery. This is 24 hours post-operative, demonstrates high resistance flow and almost absent diastolic flow. So we said that this can be common and can potentially be a normal finding. Common finding postoperatively and likely due to increased vascular hepatic resistance, secondary to swelling or an interstitial edema of the graft. So if we move further out from that postoperative period, we should, in our main hepatic artery, we should see return to a more low resistant waveform. In this case, they Dopplered within the liver. We were able to demonstrate a normal left hepatic artery after the administration of a vasodilator. So congestive heart failure. So main portal vein demonstrates markedly pulsatile flow pattern. This is now a patient. We're imaging our main portal vein. You can see that it's pulsatile. So this isn't our normal, continuous portal vein waveform, and this is a result of a patient with congestive heart failure. The image below, we're Dopplering the middle hepatic vein and demonstrates an increased A wave, which is also consistent with right heart failure. We have that large A wave above the baseline here, which is also indicative of a patient with right-sided heart failure. So if we look at some of the other complications that could potentially arise from a transplant, we have our vascular complications. The second most common cause of graft failure after allograft rejection. We can also have hepatic artery thrombosis or stenosis, which could lead to hepatic infarct. We can also wind up with pseudoaneurysm. We run the risk to creating an arterial venous fistula. We can potentially wind up with portal vein thrombosis or stenosis, IVC or hepatic vein thrombosis or stenosis. Some biliary complications, we have bile duct obstruction or stricture, potential narrowing of that bile duct. We can have anastomotic or connection site stenoses or blockages or narrowing. There could potentially be stone formation within the bile ducts. There's the potential for bile leak, bilioma, biliary necrosis, or cholangitis, so inflammation of the ducts. So it is, I know you guys think of like gallstones, like if a patient has their gallbladder removed, they still can't develop gallstones, but a patient still could potentially develop a stone or a calcification within the bile duct itself, even if they don't have a gallbladder. So it is a potential complication. Some other complications could be a hematoma, developing a hematoma post-surgery, abscess formation. So if infection found its way up to the liver, particularly in the cases of the patients that had that polydocal jejunal anastomosis, we could wind up with some bacteria coming up from the intestine, creating abscess within the liver. Infection as well, so it could be post-surgical infection, could be infection again coming from the intestine, recurrent hepatitis. Patient can wind up with portal hypertension. We've had issues with splenic infarct. Other complications could be recurrent malignancy, as well as something called post-transplant lymphoproliferative disorder. That's the name that's given to a B cell proliferation due to a therapeutic immunosuppression after organ surgery. These patients may develop infectious mononucleosis like lesions or polyclonal polymorphic B cell hyperplasia. Some of these B cells may undergo mutations which may render them malignant and give rise to lymphoma. So when we're talking about vascular, hepatic artery thrombosis is going to be the most common vascular complication. This has a high mortality rate if transplantation or thrombolectomy or thrombolysis is not immediately performed. Most patients will require retransplantation, unfortunately. Patients typically present with biliary tree infection or biliary leak, abnormal bilirubin, pain, and fever. So with hepatic artery thrombosis, normal diastolic flow to absent diastolic flow can be visualized, dampened peak systolic velocities. There could be loss of arterial flow and non-visualization of the hepatic artery as well. So if it's completely thrombosed, we're not going to see it. Hepatic artery is the sole vascular supply to the biliary system in the liver transplant patients. It may lead to biliary ischemia and necrosis. Common findings: hepatic infarct, abscess, and biliary necrosis. So in 4 to 12% of adults and then 40% of pediatric recipients, this can occur. It often occurs within 6 weeks after transplant, but develop several years later. Bile ducts of the liver are exclusively supplied by small branches of the hepatic artery. So ultrasound is a good early stage and is good in the early stages and not as sensitive in late stages because of collateral flow. So main takeaway from this slide is that the hepatic artery is what supplies the blood flow to our biliary system, our biliary tree within the liver. So the liver itself will get blood from the main portal vein. So the liver tissue itself is getting that blood supply, but the actually biliary tree is receiving its blood supply from the hepatic artery. So if we have a blockage or thrombosis of this hepatic artery, that biliary system, the biliary tree, the bile ducts, they're not going to receive their blood supply. So they're going to start becoming necrotic and break down, which can lead to leakage of that bile, biliary ductal dilatation, as well as abscess formation within the liver. So this leads to that biliary ischemia and necrosis. You can imagine it would have a high mortality rate. Hepatic artery thrombosis, so risk factors. This includes size mismatch in donor and recipient arteries. The patient has small vessels, especially in the pediatric transplants. If there's underlying hepatic artery or celiac artery stenosis. If it was a complex arterial reconstruction. If there's prolonged ischemic time for the donor liver. If there's a blood type incompatibility, could lead to a hepatic artery thrombosis, allograft rejection, issues with surgical technique, or even prior liver transplantation, and also potentially cytomegalovirus infection. Some pitfalls, poor technique. If there's very low velocity flow due to poor cardiac output or hypotension, high grade hepatic artery stenosis or severe vasospasm could lead to poor or non-visualization of hepatic artery flow, which could mimic hepatic artery thrombosis. So if there's poor visualization or non-visualization of that hepatic artery, this could mimic stenosis. Patient could potentially have a vasospasm, which can appear as a high-grade hepatic artery stenosis. So it's hard to differentiate between the two at that point. So collateral arterial flow in the transplanted liver may develop in patients with hepatic artery thrombosis, especially in children. These collaterals are often not enough to sustain the transplant and are recognizable by a TARDIS parvis waveform. It may be difficult to visualize. This may be difficult to visualize due to vasospasm or parenchymal swelling post-surgery. So this is a patient with hepatic artery thrombosis. So we have a transverse image demonstrating flow in the main portal vein, but no evident flow in the adjacent hepatic artery. 2 days later, again, intrahepatic portal venous flow, but no arterial flow could be obtained. CT shows multiple wedge-shaped areas of low density consistent with multiple infarcts and liver necrosis. You can kind of start seeing it developing some areas of necrosis within the liver parenchyma, so it's not nice and homogeneous as you progress. Again, no hepatic arteries identified. Main portal vein shows non-occlusive portal vein thrombosis at that point. So over here on the CT, you can see the main portal vein, and this was an area showing the portal vein thrombosis, partial portal vein thrombosis. So ischemia may cause that starry night appearance or starry sky. So this is echogenic appearance of the liver transplant. Again, it's another image showing hepatic artery thrombosis. So we can see a nice main portal vein. We're not able to detect a hepatic artery. Again, this is going to be our most common vascular complication. So this is hepatic artery thrombosis in a 45-year-old male with worsening results on liver function tests 8 days after an orthotopic liver transplant for alcoholic cirrhosis. Subcostal oblique color Doppler image of the right hepatic lobe shows a avascular cystic space within the hepatic parenchyma, which represents infarct. Flow is demonstrated in the adjacent hepatic veins. No hepatic artery was seen at the porta hepatis or anywhere in the liver on color Doppler spectral or spectral imaging. That's a good point too. If you're suspecting hepatic artery thrombosis, look for arterial flow within the liver itself. So you may not be able to visualize it nicely, at the porta hepatis, coming in the area, the main portal vein. Try and look for hepatic artery flow within the vessel and within the liver itself, because those portal triads are still gonna, maintain throughout the liver. So you'll have hepatic artery flow running with portal flow in the liver itself. So you'll have your bile ducts, your portal vein, bile ducts, your portal veins, and your hepatic arteries all running together within the liver. This is an angiogram, again, showing the hepatic artery thrombosis. Angiogram obtained after thrombolysis shows improved vascularity to the hepatic arteries. So it's before and then after return to flow. So the second most common vascular complication now is still involving the hepatic artery. So this is going to be now hepatic artery stenosis. So this is either an early finding or a late finding. And it's usually seen at that anastomotic or that connection site. Again, this hepatic artery stenosis may lead to biliary ischemia and necrosis. We said that hepatic arteries what supplying blood flow to our biliary tree and may progress to hepatic dysfunction or graft loss, so loss of that organ. Risk factors include surgical clamp injury, intra-arterial catheter injury, rejection or surgical technique, or interruption of the vasovasorum. Doppler features for hepatic artery stenosis, we're going to have increased systolic velocities greater than 200 centimeters per second and post-stenotic turbulence. We're also going to look for other features, that we see with any sort of artery stenosis. We're going to look for our post-stenotic tardus parvis waveforms. So distal tardus parvis waveforms, distal to that stenosis. We're going to look for increased acceleration times. So acceleration times greater than 0.8. So meaning that it takes longer for that blood to accelerate. And we're going to also have decreased resistive indices, which are going to be less than 0.5. So this is going to be our most accurate predictor of hepatic artery stenosis. So this occurs in 2 to 11% of transplants. It usually occurs at the connection within 3 months. We may form thrombus secondarily as a result of a stenosis. These patients will have abnormal liver function tests. A disruption of the vasa vasorum intimal injury could be a result from perfusion catheters, perfusion catheter ischemia, and hepatic insufficiency. Which results in hepatic insufficiency, biliary strictures, sepsis, and finally graft loss. If intraparenchymal tardius parvis waveforms is seen, it is likely due to hepatic artery stenosis. So, excuse me. So with that, we have normal RIs should be between that range of 0.5 and 0.8. First 3 days, again, maybe as high as maybe greater than 0.8. So again, that hepatic artery waveform post-op will most likely be high resistance, but within several days, we should return to our normal range. So hepatic artery stenosis. So this is a distal main hepatic artery, demonstrates tardius parvis waveform. So again, we have low velocities. We have that increased acceleration time. So our time to get to our peak systolic velocity is increased. We have higher diastolic component. We continue to interrogate and we see increased velocities at the site of stenosis in the main hepatic artery. Again, this may be obscured by bowel gas, so we may not actually be able to visualize that stenosis or that narrowing, but we can appreciate intrahepatic or distal hepatic artery tardius parvis waveforms, which would indicate, a more proximal stenosis. So that's when you have to kind of use your vascular brain to be like, all right, this waveform is abnormal. This looks like a tardius parvis waveform. So there's got to be a proximal stenosis somewhere that I'm not seeing. So this patient had an angiogram that showed the stenosis more proximal. Doppler of the distal main hepatic artery and intraparenchymal hepatic artery is performed in patients presenting with evidence of dilated bile ducts, biliomas, or abnormal liver function tests. So this is consistent with biliary tract abnormalities in order to look for tardius parvis waveforms indicative of more central stenosis. Good picture. We're Dopplering again an intrahepatic, left intrahepatic artery. Again, this shows our nice tardius parvis waveform. So similar waveforms may be seen in the early postoperative period. The tardius parvis waveform is a much more specific finding for the presence of hepatic artery stenosis 48 hours after transplantation. So another thing to remember, a very low grade hepatic artery stenosis may not show the tardius parvis waveform. Therefore, in this case, a CTA or an angio should be performed if unexplained biliary problems continue to persist. The ultrasound appears normal. It's there's a similar waveform may be seen in the first 24 to 48 hours following transplant due to peripheral hepatic vasodilation in response to reperfusion injury. So sometimes we can wind up with what appears to be a tardive parvis waveform because we've now reconnected that liver, back to a blood supply. So this organ now is reperfusing. So you may see this actually in cases. I know the DMS students with in torsion cases with particularly ovarian torsion or testicular torsion. If you have torsion and then the testicle or ovary detorses and you have sudden reperfusion of that organ, you may wind up with an increase in flow or a tardive parvis waveform because you now have reperfusion of that organ, like that organ all of a sudden is drawing in blood flow. It may create an abnormal waveform because the organ is not being reperfused by blood. So hepatic artery stenosis, then these patients have poor liver function tests or biliary ischemia. So in these slides, we're able to see over here turbulent hepatic artery flow with high velocities, a very turbulent waveform pattern. And then as we move further away from that area of stenosis, we wind up with more of a tardive parvis waveform. We have significantly reduced velocities with that delayed systolic acceleration time or prolonged acceleration time. So hepatic artery stenosis pitfalls in treatment. Very low-grade hepatic artery stenosis may not be exhibited on Doppler findings. So these patients may need to have a CTA or angiogram to be performed to rule out abnormalities if the ultrasound appears normal, but unexplained biliary problems exist. We have to optimize our color Doppler sites to detect flow and use power Doppler. Treatments include placement of a stent, potential angioplasty, surgical revision, or even the potential for retransplantation. Another complication could be a hepatic artery pseudoaneurysm. So these are rare, less than 1%, around 1% of patients. These present as asymptomatic or present with fever, biliary colic, or signs of hemorrhage. So signs of hemorrhage would be a dropping hemoglobin, hematocrit. These are usually seen at that anastomotic or connection site. They're an extremely serious vascular complication due to high risk of hemorrhage or rupture and could result in organ failure. The majority of them are going to be extrahepatic. And again, they usually occur at that arterial connection site due to interpretation of interruptions of intimal lining or surgical breakdown or hepatic artery angioplasty. We could potentially see a hepatic artery pseudoaneurysm intrahepatic as well. So this would be more of a mycotic in origin, so from bacteria, or may develop secondary due to iatrogenic injury following a percutaneous biopsy or some sort of biliary intervention. So with any pseudoaneurysm, again, we're going to have our telltale yin-yang flow pattern within the actual aneurysm itself. When we Doppler the neck, we should see our bidirectional to and flow Doppler signal, which is seen with all pseudoaneurysms. If there's a wider neck that's present, this may be a more disorganized flow pattern. Treatments include percutaneous embolization, exclusion with covered stent placement or surgical revision. So this was an intrahepatic pseudoaneurysm. You can see within the left lobe over here, you have a large area of swelling blood connected to a small neck. So this was following a liver transplant biopsy. Other thing to remember too with pseudoaneurysms, they're going to be arterial in nature. So if I Doppler something and I'm not getting an arterial signal within it, it's not a true pseudoaneurysm. So AVF. So hepatic artery to portal vein fistula. These are extremely uncommon, often arise following liver biopsy. Most are small and resolve spontaneously. So ultrasound findings. So with any sort of fistula, we're going to have turbulent flow because we're going from a high pressure arterial system into a low pressure venous system. So we're going to see color aliasing. There's going to be soft tissue bruising at the site of the fistula. We have arterialization of flow in the draining branch of the portal vein. So if we Doppler portal vein and we see arterialized blood flow within it, that should raise the signs that there could be potentially an AVF. Within the artery component, we're going to have low resistant, high velocity flow feeding in the hepatic artery. So it's going to be similar to fistulas that we see in the extremities. In the artery we have high velocity, low resistant. We have turbulent flow within that anastomosis or connection. You'll potentially feel a bruit. I'm sorry, hear a bruit. Again, our classic arteriovenous fistula flow, so very high velocities, very turbulent, high peak systolic, high end diastolic velocities. We have pulsatile flow now in the left portal vein, rectangle of small vessels. So this is a small AVF surrounding it. We're winding up with more pulsatile flow in that portal vein. Another potential complication is going to be about portal vein thrombosis. So this is a rare finding in 1 to 3% of liver transplant patients. Usually involves the extrahepatic, so portion of the portal vein outside of the liver. Some risk factors could include previous portal vein surgery, like a tip shunt, recipient portal vein thrombosis history. If the patient's in a hypercoagulable state or condition, vessel redundancy, donor versus recipient vessel diameter mismatch. So the classic manifestation of portal vein thrombosis is going to be portal hypertension with gastrointestinal bleeding. Again, same that holds true with portal vein thrombosis in a patient without a transplant. We're still going to see those same characteristics in the patients with their transplant. So we'll see ascites, development of ascites. They'll have liver dysfunction or failure and peripheral edema. So the patient's extremities are going to appear edematous, they'll have swelling in the legs, feet, swelling in the arms. So again, ultrasound findings for portal vein thrombosis. So we use a low velocity setting to avoid technical errors. So it's important to utilize your power Doppler because we may potentially have just slow flow within that vessel. So we don't want to call something thrombosed
If there still is actually flow, it's just very stagnant and slow. Lack of blood flow, most commonly in the extrahepatic, it's most commonly seen in the extrahepatic portal venous segments. We also have to remember that thrombus could be non-occlusive. So thrombus may appear hypoechoic. So it may be difficult to actually visualize the thrombus itself. So we're going to look for filling defects. So we want to make sure that that portal vein, fills with color wall to wall. So a small non-occlusive thrombus we may overlook. So you also want to make sure that your color gain settings are not set too high, that you're actually bleeding out and not covering, or masking that small thrombus. Treatment for portal vein thrombosis includes thrombolysis, so medications to break up or dissolve that thrombus. Thrombolectomy, so actually surgical procedure going in to remove the thrombus. Potential stent placement to keep that portal vein open once they've removed the thrombus. Angioplasty or surgical revision with a graft. So this top picture is showing a partially occlusive main portal vein. So you can see here the main portal vein entering into the liver. We have echogenic intraluminal echoes within the main portal vein. And when they're Dopplering, we're able to get some flow, partial flow going around that thrombus. So this patient had a CT as well that showed a filling defect in the main portal vein. So the left image over here, again showing main portal vein. The patient following a liver transplant, so Briggs scale shows thrombus, all the arrows pointing to thrombus. This tech went crazy with the arrows. So here we can see, main portal vein coming in. So our portal splenical confluence. So this is probably superior mesenteric vein coming in, spleen vein. It looks like there's thrombosis involving both the SMV and splenic veins as well. Right image shows a subcostal long axis of the main portal vein, the distal thrombus. This is a portal cavernoma. So this is again cavernous transformation of that portal vein. This is a 54-year-old man, 3 years after a liver transplant. So sonographic image shows multiple collaterals replacing the main portal vein from chronic portal vein thrombosis. So this is sometimes referred to as a bag of worms appearance. So this is that cavernous transformation of that main portal vein. Portal vein thrombosis, stenosis, I apologize. So ultrasound findings. So these usually occurs at the anastomosis at those connection sites. We have focal narrowing of the main portal vein to less than 2.5 millimeters. This results in high velocity flow with distal turbulence. And we have a peak portal vein velocity that's going to be greater than 125 centimeters per second, or a velocity ratio of 3 to 1. So if we're Dopplering the main portal vein and we have 100 centimeters per second in one segment, and then it all of a sudden jumps up to 300 centimeters per second in the second segment, more distally, that would fall into our velocity ratio. So this is something that's going to be more common due to vessel mismatch size, particularly in pediatric transplant patients. You have a large, vessel for the recipient connecting to the small vessel for in small native vessel in the recipient. So the donor has a large vessel, recipient has a small vessel, which can create that vessel mismatch leading to a stenosis. Portal vein stenosis, color Doppler demonstrates narrowing and a focal color aliasing in the main portal vein. So velocity is proximal to stenosis. We have 30 centimeters per second. And velocity at the stenosis, we get 166. So we have a ratio of 5.5. So that's will be fall into that criteria of high grade stenosis, portal vein stenosis. So you can appreciate, you have your main portal vein, you get an area of aliasing. So you want to investigate that area of aliasing. Another thing that we could potentially look for too is, in this case, we're seeing post-stenotic dilatation. So we have our main portal vein, we have an area of stenosis, and then distal to that stenosis, we wind up with dilatation of the main portal vein. So this is again another image showing a portal vein stenosis. So you can appreciate some narrowing within that main portal vein, area of narrowing in your grayscale. And when you do your color Doppler interrogation, this was kind of just showing the velocities in the different segments. Proximal to that stenosis, we have very low velocity, and we have a dramatic increase at the stenosis and immediately distal. So these waveforms show a greater than 6-fold velocity in the post-stenotic segments relative to the velocity in the pre-stenotic segment. And these findings are consistent with a significant stenosis. IVC or hepatic vein thrombosis or stenosis. So this is rare, and incidence of complications is going to be less than 2%. So predisposing factors for thrombosis, again, it can be hypocoagulable states. If there's an underlying stenosis somewhere, or injury during surgical manipulation of the vessels. Predisposing factors for stenosis could include vessel kinking, size discrepancy between donor and recipient vessels, compression by a large hematoma or other fluid collections, or severe graft edema. So suprahepatic IVC kinking can occur from organ rotation. IVC stenosis or anastomotic narrowing or extrinsic compression from graft swelling, as well as hematoma or fluid, as well as IVC thrombosis or stenosis, may also be due to vessel length and retransplant, and may lead to retransplantation. Sonographic features for IVC and hepatic vein thrombosis and stenosis. So thrombosis, we're going to see intraluminal echoes. There'll be no blood flow present if it's occlusive. The treatment's going to be angioplasty. If it's stenosis, we'll see increased velocities, focal color aliasing. potentially see reverse flow or loss of phasicity of the hepatic waveforms. Pulsatility index of less than 0.54 be suggestive of outflow stenosis. So again, we're looking primarily, at those connection sites. So we're going to be looking around that IVC, where the hepatic veins or the donor IVC connected to maybe the recipient's hepatic confluence. So in this, we see a transverse grayscale image showing the IVC with thrombus in it. See thrombus extending into right hepatic vein, as well as a pleural effusion. D is our CAT scan showing thrombus in the right hepatic vein and IVC. So this was a patient with IVC stenosis, 48-year-old male, 9 months after a liver transplant. Angiogram shows the IVC stenosis. So stenosis was successfully treated with a wall stent. Again, this is just showing IVC thrombosis versus IVC stenosis. Stenosis will have absence of flow, intraluminal echo. Stenosis, we should have color aliasing, turbulent flow. Then biliary complications. So some biliary complications we can encounter are going to be bile duct obstruction or stricture, anastomotic stenosis, stone formation, bile leaks, bilioma, biliary necrosis, or cholangitis. These usually occur within 3 months. They occur within 5 to 15% of transplant recipients. More common in right hepatic lobe transplants. Symptoms ranging from abdominal discomfort to sepsis, biliary leakage or / bilioma from biliary necrosis of the intrahepatic duct or common bile duct is usually indicative of hepatic artery thrombosis or stenosis. Most biliary strictures occur at the connection sites, secondary to scarring or fibrosis. And presence of biliary complications, particularly intrahepatic pathology, prompt evaluation of hepatic artery for thrombosis or stenosis. So if we see complications within the intrahepatic biliary system, we should be evaluating the hepatic artery because it could be an issue resulting from hepatic artery stenosis or thrombosis, because again, those hepatic arteries are what supply the blood flow for this biliary system. So hepatic artery is the sole blood supply to the biliary tree in the transplanted liver. So this is just showing focal narrowing of the middle portion of the common bile duct. Arrows at the surgical anastomosis site. See our CBD. We got a focal arrow narrowing there at that surgical connection site. So biliary necrosis. So we have a periportal area of decreased echogenicity and inferior area of increased echogenicity. In this case, the choleangiogram demonstrated irregularity and dilatation of the biliary tree and a focal collection of contrast or bilioma. These findings are consistent with the extensive biliary necrosis. These findings are worrisome for bile leakage and hepatic ischemia. Patients with such findings should be carefully evaluated for biliary and hepatic artery abnormalities. So bilioma, this is a collection of bile that results from a bile leak. The fluid collection is usually adjacent to the biliary tree or that anastomosis, that connection. And then on the picture on the right shows cholangitis. This is a recurrent sclerosing cholangitis. So we're able to see mural thickening of this CBD wall. So we have wall thickening actually of that common bile duct. So angitis is inflammation or swelling of that bile duct. So cholangitis. So recurrent sclerosing cholangitis. This is sagittal ultrasound image showing mural thickening of the common bile duct. And this can occurs 350 days post-transplant. This condition permits bacteria to invade the liver allograft. Again, so this is just a list of some of those other complications that we potentially encounter: hematoma, abscess formation, infection, recurrent hepatitis, portal hypertension, splenic infarct. We have recurrent malignancy. So perihepatic fluid collections. So our perihepatic hematoma and right-sided pleural effusions are common postoperatively. Intervention is needed if these increase in size or cause falling hematocrit or respiratory distress. So hematoma are often located in the left lobe of liver, Morrison's pouch, in the gallbladder fossa, along the falciform ligament. Hematomas are avascular, so there should be no vascularity within them. If there is vascularity within a hematoma, then you should be suspicious for pseudoaneurysm and interrogate further, try and find the neck, try and find where that bleeding is coming from. Ultrasound is used to localize fluid and to assess for change in size or echogenicity or to guide intervention. Diagnosis of fluid content requires aspiration. So for us to be able to ultimately tell what that fluid is, we need to aspirate some of it and test it. So we can describe the fluid sonographically. Is it simple? Is it complex? Is there any vascularity to this fluid collection? So fluid collection should resolve 7 to 10 days post-surgery. You also want to see if there's any presence of gas within the fluid collection. So this could indicate an infectious process as well. This is a perihepatic fluid collection. So over here we can see in our Morrison's pouch. So we have our liver, our right kidney, the space between the two. This is an elongated complex echogenic collection between the inferior surface of the liver and the right kidney, consistent with the hematoma. So B shows a large complex hematoma in a different patient. Aspiration would be performed in patients with fever, elevated white blood cell count to exclude superinfection. In this patient, we see a large anechoic perihepatic collection in a different patient. So a bilioma or loculated ascites may also have a similar appearance as well. Again, these patients we want to closely monitor with interval ultrasounds to evaluate for increasing size and monitor their status in terms of their hemoglobin and hematocrit, looking for any drops in hemoglobin and hematocrit that could potentially indicate that they're bleeding. So surgical exploration and evacuation or angiography to embolize a bleeder is recommended in patients with an enlarging perihepatic hematoma or evidence of significant blood loss. So other complications also include abscess. So this is a transverse view, shows focal mass in the left hepatic lobe, and the mass demonstrates highly echogenic air and posterior dirty shadowing. So we can see these echogenic foci within the left lobe of the liver, which is indicative of air. So that ultrasound beam is hitting these air pockets. We get a lot of reflectivity, and then we get posterior dirty shadowing posterior to that area of air. So this could potentially either be, could be pneumobilia, air within the ducts, or more likely an abscess formation. So again, these patients would have to be monitored, with labs. So if their labs, came back positive for elevated white count, fever, you can lean more towards that diagnosis of an abscess formation. So abscess transverse image shows focal mass in the left hepatic lobe, again demonstrating highly echogenic air and posterior dirty shadowing. So this one now is a hematoma. A transverse image shows a rounded hematoma as a focal, well-defined cystic structure with internal echoes. So you can see a more cystic component and anechoic up here, and a more solid component down here. So common with hematomas, you'll see a defined fluid level. So typically the more dependent portion, it's going to start, consolidating and forming into that clotted area. So you'll see more of a solid echogenic portion in the more dependent portion of that lesion, where is the more superior or anterior portion of that is going to appear more cystic. So that's usually a characteristic of a hematoma. So this is a hepatic abscess. So we see a complex hypoechoic rounded area at the tip of the left lobe. A patient with distal hepatic artery thrombosis, resulting in hepatic infarct, which became superinfected. B is a complex and round, sharply marginated collection in another patient with hepatic abscess and hepatic artery thrombosis. So in these patients, they had the hepatic artery thrombosis, which led to death of those biliary trees, or the biliary ducts. There's probably leakage of that biliary duct into the liver, which led to infarct of that liver, and then abscess formation, infection and abscess formation. It's just kind of a breakdown for some of our intrahepatic masses. So intrahepatic abscess will appear as a complex fluid collection with variable echogenicity. Biliary necrosis or hepatic ischemia will have hypoechoic area of liver parenchyma near the portal triads. So it's going to be hypoechoic, darker. Hepatic infarct will have typically well-defined or rounded or peripheral and wedge-shaped. These will have variable echogenicity. So the infarct will be well-defined. They'll appear round or potentially wedge-shaped. Malignant tumor or that PTLD, PTLPD, the post-liver transplant lymphoproliferative disorder. This will appear as a single or multiple liver masses with diffuse infiltration of the liver, or a portal mass encasing the portal vessels or common bile duct. Liver transplant recipients are at increased risk for developing malignancies. So intrahepatic abscess formation most often occurs in the setting of liver infarct or biliary necrosis in patients with hepatic artery thrombosis. The outer margins for abscess may appear irregular and thickened, surrounding a more hypoechoic or anechoic center. The presence of echogenic speckles with ring down is indicative of air, and is highly specific finding for abscess formation. So we look for those echogenic speckles with ring down artifact and dirty shadowing. Or telltale signs for an abscess. An abscess will be centrally avascular, but may demonstrate increased peripheral vascularity. So that's another thing too, if you're suspicious for abscess formation. So you'll have no vascularity within that central abscess, but you might wind up with some hyperemia, some peripheral vascularity around an abscess. So above is a recurrent hepatocellular carcinoma in a 49-year-old male, 10 months after liver transplant for alcoholic cirrhosis. And below is a patient with the PTLD. You can see they look kind of similar in appearance. You have a well circumscribed mass with borders. It's complex, heterogeneous. We'll do this next week. Any questions about any of this liver stuff, transplants? So again, Doppler interrogation is going to be our most useful too. We want to make sure that we have good proper flow direction in our main portal vein. If we see any abnormalities within our flow, we have to, expand our search
Look at the superior mesenteric vein, look at the splenic veins, check for splenomegaly. In cases of portal vein thrombosis or portal hypertension, we're going to see our other signs, our ascites. Perihepatic varices could potentially develop, splenomegaly. You look for, abnormalities in the flow. Like transplants were the most common vascular condition for transplants is going to be our hepatic artery thrombosis. Second is going to be the hepatic artery stenosis. So hepatic artery thrombosis, we worry about biliary ischemia because the hepatic artery is that main supply for blood flow to the biliary tree. So we're going to ensure that there's no thrombosis within the hepatic arteries. So hepatic artery flow immediately post-op will appear high resistance and should gradually lower resistive indice to appear as our normal hepatic flow, nice low resistance. Hepatic artery stenosis, we're going to look for those tartar parvis waveforms that can potentially indicate stenosis. So if we're Dopplering, in the distal hepatic artery or the hepatic artery intrahepatic, and we see a tartar parvis waveform, we should suspect that there's a stenosis more central that we're potentially not seeing. And this patient should be recommended for follow-up. What else? Does anyone know anyone who's ever had transplants? What did kidney? Yeah. Who had a kidney transplant?
Friend's daughter, and then she donated her kidney. She went for national. So she was donated her, so she.
Oh, wow.
Yeah, that's her daughter's second. I think it's like. I think it was like within 5 or 6 years. She had to have the second one.
Any questions for you guys at home?
No, I'm okay.
You good? All right.